I think it's important to point out that there are a fair number of women with early stage breast cancer in whom we would choose to delay surgery to give them their systemic therapy first. But that's largely patients with triple negative breast cancer and HER2 positive breast cancer. And that makes up about 30% of our breast cancer diagnoses. So the 70% that are hormone receptor positive, the majority of them usually would have surgery as their initial intervention. I'd say a small fraction, maybe 10 to 15%, would have preoperative systemic therapy in our practice, which means about 50 to 55% of the patients that we saw as new patient referrals during COVID had a change in the way we would normally do things by sequencing this neoadjuvant or preoperative endocrine therapy and then surgery.
I only had a few patients that I personally had to delay and had to talk to. Certainly no one was happy about it, but I think everyone was certainly aware of what was going on. And so I do think there was a lack of surprise. And we did actually try to undertake a partner study with this. And we actually talked to some breast cancer patients as well as prostate cancer patients about just what their experiences were with their surgical delays. And in that particular study, one of the stronger things was, in fact, that there's a range of emotional reactions, but one of the strongest is the fact that there wasn't any surprise. People were kind of expecting this. And there were some other themes that actually helped them to accept the fact that they had to undergo these surgical delays. And certainly having some sort of delay strategy like neoadjuvant endocrine therapy certainly helped a lot.
I think we can go so far as to tell our patients, in fact, that they should still expect an excellent prognosis from their early stage hormone receptor positive breast cancer. And that excellent prognosis is not negatively impacted by this delay that they've experienced.